I just have that I think Dr. Trish Edney should be probably listed under the members present, as she was there as a substitute member. If we could amend that. I think Councillor Mohammed had sent her apologies for that meeting. That should be noted as well. And there's actually a spelling error in Trish Edney's name at 5.4, if that could be corrected just for the record, just because obviously with digital records people do search names, so if we could just get that spelling corrected for the final publication, thank you. Okay, public questions and petitions. Do we have any public questions or petitions today? Nothing today, thank you. And so on to item 7, which is the CQC Inspection Framework. Now this item, we haven't received a report on this item, and having consulted with Alexis Chappell, the Director of Adult Social Services, we're going to take that item through the Adult Health and Social Care Committee, so that item 7 is remitted to that committee and won't be considered at this committee unless members have any objection. Okay. Right, so item 8, if I can invite our visitors who have come to present on the CAMHS CQC inspection update. Thank you. So if you'd like to both introduce yourselves and tell us what your role is within CAMHS, and then if you want to present your report, and perhaps if you can give us a little bit of the historic background of where we've come from with the inspections over recent years, that would be helpful. Thank you.
Hi, my name is Yvonne Millard. I am the Chief Nurse at Sheffield Children's Hospital, and my role is quality, safety, patient experience, and I am the lead for CQC.
Thank you. My name is Chef Perring. I'm the Medical Director at Sheffield Children's. Not CQC as it says there, so, and the exec with specific responsibility for mental health.
Thank you. So we'll talk you through our paper. I thought it would be useful to give you a little bit more information about our lodges, because we don't want to assume that you know a great deal of them. So within the CAMHS services, we have some inpatient lodges as well as community services. So we have 3 inpatient children and young people lodges. They're called the Becton Centre. Each have different age ranges and remits. So you'll hear us talk of 3 lodges. One is called Sapphire Lodge. That's a 10-bedded general adolescent unit. And the children and young people that reside there are between 13 and 18 years of age. Generally, these young people will present with a range of difficulties. They can range from low mood, eating disorders, self-harming behaviours, suicidal ideation and psychosis. Our second lodge is called Emerald. That is managed through NHSE. That is a 9-bedded unit. It cares for young people presenting with similar disorders. The difference is the children that reside there are aged 13 and under, so it's a younger unit. Our final lodge is called Ruby. It's the smallest lodge. It has 7 beds there, and it's an unusual lodge in that the children and young people that reside there are aged between 18 and 17. But it is one of the only providers that caters for young people who have a mental health diagnosis coupled with learning disability and autism, which makes it a very complex unit to manage. Our community services are wide. They cater for children and young people requiring mental health services across Sheffield and the wider region. There are 9 teams in those hubs. I won't go into great detail. They range from specialist eating disorder and treatment teams, forensic CAMHS, a day unit and outreach service, and general mainstream CAMHS. So they are the services that we are talking to, and I'm going to let my colleague talk about the history of CQC and where we are today. Thank you.
Thank you very much. So today we're bringing to you the outcomes of 3 inspections. The first one was the CAMHS Inpatient and Community. The second was a system review in Sheffield under the Mental Health Act. And the third was a regular Mental Health Act review of Ruby Lodge. So the first one, I think the last review, if you look in your notes, you'll see that there have been a sort of a relatively recent review in 2019 around the inpatient and community CAMHS. And this was the outcome of a more recent review in the summer of last year. And the review was generally positive, and we're proud of the work that our colleagues actually did in this area and have undertaken to move things forward. So the inpatient CAMHS maintained its good overall position and was good in 4 out of the 5 key areas of inquiry. And whilst the community CAMHS remained as required improvement overall, it had moved and requires improvement to green in 3 of the 5 areas. So it recognises some of the work that has been done then. And I think it also, we are proud because of the fact that actually the CQC, having come back after COVID, have been quite tight in their inspection regimes. So for us to even maintain the good and to improve in the community was a real positive for us. Within the community, the biggest area is the waiting list size and the effect that this has both for the waits for the services, but also the caseload for individual clinicians. And so there is some immediate and longer term work that is taking place to support that. The second review was the Sheffield System Review under the Mental Health Act. Just to sort of clarify, CAMHS services go up to the age of 18, but in the city, physical health transitions at the age of 16. So what that means is that there are different pathways for 16 and 17-year-olds as opposed to those who are under 16. So with that in mind, Sheffield Children's is the health-based place of safety, so the ED is the health-based place of safety for less than 16-year-olds. And children and young people who attend are supported by our STAR team, which is one of the community teams, who also support that. So they work both in the hospital and work with the young people when they go out back out into the community. Those who are 16, 17-year-olds, the health-based place of safety at the moment is at the Northern General's ED, where if they are in crisis, they are assessed by Sheffield Health and Social Care's liaison team. So this review looked at all those services, and there were a number of findings from that. In particular, ones I'd like to highlight were the conflicting interpretations about availability of services and their accessing criteria, including the route of access to specialist CAMHS advice for 16 and 17-year-olds. Also comments about the place of safety. They've mentioned that a new health-based place of safety would be opened at Beckton. This is actually a unit of 136 suite that has previously been open, but unfortunately due to staffing issues has had to close and has been closed now for probably over 18 months. Following this review, a system-wide action plan has been put in place, which is being worked through at present. And then the final area is the mental health monitoring visit of Ruby Lodge. So as Yvonne mentioned, this is the lodge that looks after children and young people with mental health issues, but on a background of learning disability. These are monitoring visits and are routine or relatively routine. They are unannounced. Within that, it was they highlighted areas around the use of the Mental Health Act and compliance with the code of practice, particularly in relation to the work that goes on with the parents of young people. And again, an action plan is in place and is sort of being taken forwards. So overall, as a trust, we welcome the visits of the CQC, both to show the improvements that we've already made and are proud of, but also for them to highlight areas for improvement that we can take forwards. So there should be a continuous cycle of improvement, and we're proud of the work that our staff are doing to actually care for these children and young people, because at the centre of this is a set of very vulnerable children and young people who are in a very difficult place at the time they come into contact with our services. So everything that we can do to support them is important. Thank you.
Thank you very much. And thanks for all the information that you've provided in the report. I'm going to open up for members to ask questions, if that's all right. Any members? I'll kick off if you like. Councillor Mohammed.
Okay, me first? All right, thank you. So thank you for the report. I thought that was really informative. Just in terms of some of the feedback that was provided in terms of the inspections, and a lot of the feedback that we've had from communities and members is always about access and waiting times. Based on the feedback, I mean, it's very sort of top level, sort of a summary, and it says that you've addressed some of the points going forward. I think I just want more information about how access now has been made easier, and people being able to navigate the system, because that's also another issue that keeps coming back, that is getting a CAMHS appointment is very, very difficult, but it's being able to navigate the system, and usually the ones with the social capital to be able to do so, the ones that get the appointments, and other people struggle. So how have you managed to address that?
Thank you. I think access is and probably continues to be something that we need to work around. What we have is a waiting list that has increased significantly over the last few years. Some of that has been around the ability to undertake activity, but probably more important is the number of young people who are actually accessing services. And so that has increased waiting times. We are looking at other areas and ways of sort of supporting these young people. So there is work that's going on with an external provider to provide online sort of sessions with young people who are risk assessed to be able to take that, so that we can start to move some of the sort of those young people who are able to be supported in that way, so we can take them and allow them to have that access to enable us to concentrate on the sort of those patients or young people who need the support of CAMHS itself, as in the sort of the community service that we provide. So there is that work going on. Young people are being risk assessed as they go through, but the other bit is trying to work towards the sort of, I'm going to say waiting well, but whilst you're waiting, what can we do to sort of provide support? Finally, I think it can't be underestimated that the importance of early intervention and actually coming in at an earlier stage so that young people don't reach the crisis point where they then need to go into the CAMHS service. If we can intervene earlier, that's better.
And just follow up on that, Chair. So have the waiting times reduced, or is it still that the demand is far too high and the waiting times are still of a significant length?
Yeah, the waiting times are still significantly longer than we want them to be.
Yeah. Sorry to follow up. And is that something that you're going to the Integrated Care Board to express? Because I've read in the summary report that you'll be feeding back to the Integrated Care Board. So, is that a request for additional funding to try and help reduce those waiting times?
Yeah. The trouble is, yes, funding would be good, but actually one of the biggest problems that we have is the availability of staff to be able to be recruited. Yeah. There is a relatively small group of trained mental health workers, and actually we're all fighting in the same pool, if that makes sense. And some of it is, yes, whilst, you know, even where we've had money in certain areas, and I think an example would be the 136 week, to be able to recruit, to be able to support that work, we've not been able to recruit because it's so difficult to find people who are trained and in a position to take up those roles. So one of our biggest issues at the moment is actually recruitment rather than necessarily finances, although it helps.
Is it a retention issue, or is it just a recruitment? There aren't enough people
so
there?
I can pick that one up. I would say it's a combination of both. We've recently completed a workforce review of our CAMHS services. That has resulted in some uplifting of banding to retain our lower trained, lower banded staff, because we do find that they're leaving. So that's worked, that's been successful, and we're rolling that through now. And we've also put some more senior posts in. So I think what you would equate to junior sisters, we've increased the establishment there. So we are tackling the retention. Some of it is recruitment because the workforce do not exist. Nurses are in short supply. Mental health trained nurses are like hen's teeth. We have put a process in place now where traditionally we've had a model where you have to be a mental health registrant to work in Beckton. We're moving away from that now in a safe way, in that we recognise some of our adult trained colleagues have got vast life experience that we can use. We have children's nurses who aren't mental health registrants but have a wealth of knowledge in mental health nursing. So we're widening the pool, but the nurses aren't there for us to recruit.
Thank you. Councillor Lee, and then we'll move along the table if that's all right. I didn't see what order your hands went up, but we'll go to Councillor Smith and then Councillor Oxley.
Okay, a couple of questions was, the Northern General, you said that liaison staff from the psychiatric services offered support to people who are looking after, to the staff there who are looking after people, children admitted for emergency under, is it 106 mental health? I'm not sure what the equivalent is for children's services, but it's the 106 mental health detaining order. What was that support? What is that support? Is that just coming in and advising, or is that 24-hour care, or until some more suitable accommodation can be found? So that was the first question. And also, what are you doing about, it mentions restraint of young people at one of the hospitals, and particularly those who need nasogastric tube, and I just wondered, sometimes restraint is needed in other situations as well, and it needs to be done safely, and it's my understanding it needs to be, people need to be properly trained to do that safely. I just wondered what is in place for that one as well. And just in terms of caseloads, you say they're very large. If they're very large, what work can be undertaken if caseloads are significantly large? What actually can you do if you don't have a caseload that allows you to work on with people to give them the interventions that they need? And is that just another caseload in a different name?
Thank you.
Sorry, waiting list in a different name, you know what I mean?
Do you want to pick up the first bit and I'll pick up restraint?
Yeah, that's fine. So I presume you mean by that you're talking about the Northern General Hospital and the 16, 17-year-olds there. So the liaison service for 16, 17-year-olds, the liaison sort of is provided by Sheffield Health and Social Care. They provide daytime services there. I'm not sure whether they provide, I don't think they do provide overnight, but I'm not sort of immediately party to it, so that's, but they will be providing the full breadth of services during that time as the mental health liaison team, in the same way as they would be for a 19, 20-year-old who is admitted to the ED at Northern General with a similar problem. Sorry, the emergency department, A&E, at the Northern General. So they're looked after by the general trained staff, but there is liaison with the Sheffield Health and Social Care, who have a team within the Northern General to support them.
I suppose after my question is, are they getting sufficient support from suitably trained staff?
So there is a CAMHS psychiatrist who is on call 24/7 for the city, and there is no reason why a member of that team, the liaison team from Sheffield Health and Social Care, shouldn't call them. And you know, I know that there are instances where they are called.
I'll pick up the restraint one. So we do have very strict guidance on how we restrain children and young people. It is always a last resort. We will always try other methods, such as distraction or de-escalation. Unfortunately, sometimes restraint does become necessary. In a lot of these cases, our young people have to be fed through a tube into their nose as a life-preserving treatment. They are reluctant for that to happen. It's medically required. There are guidance on safe ways to do that. There are certain positions which we can hold a young person that can take 4 to 5 trained people to do that safely. Staff undertake something called MABO training, which is specifically about restraint. I think we're very fortunate at Sheffield Children's in that we have a further layer of staff called Enhanced Support Officers who are all trained in MABO, so they're another group that we can call on. All of our training is monitored and our compliance against the standards is monitored. Dr. Perring actually chairs the meeting, which is the restraint committee, where all episodes of restraint are put onto our instant reporting system and they're monitored at that meeting. So we've got a very good overview, I would say, of what our practice is.
Case loads. Yes, so some of the work that's been doing is around models of care that we can provide. So one of the directions that is being looked at by teams within the community CAMHS is whether we can do more group work, so that people are actually, so again, depending upon, I'm going to say diagnosis, but depending on reason why they're sort of working into or being brought into CAMHS, whether or not group work would work for them, and where that is the case, to bring people together so that you are being able to sort of work through sort of 5 or 6 people rather than just one person at a time. So that's one sort of method that is being used. The other is around, as I mentioned, using an external provider, again, to be able to allow the people, young people with certain diagnoses, to be cared for by them, where it's risk assessed to be safe to do so, to allow CAMHS to then look after the sort of those that are, you know, their sort of skill set is most useful for. Having said all of that, it doesn't get away from the fact that the waiting list continues to be very long and large, and you know, we recognise that that is the case. What I would say is that the teams recognise it as well and are trying really hard, but there's only a certain amount that they can do.
Follow up on the external provider, if you could just explain what they do, particularly, and are they private external
So they
providers?
are private.
So that one. And also, in terms of people referrals, do people get guidelines about how, who and when they should refer children to the psychiatric services?
So the answer to your first question is yes, they are a private provider, and they're obviously an external private provider, but we have worked closely with them now for a couple of years. So, and there has been built up a reasonable relationship with them, so that you know, we can work, and we know that they will refer back if they have any concerns. So there's a sort of two-way working relationship with them. I think we would all say it's not our ideal solution, but in the position that we're in at the moment, it is a very reasonable solution to take forwards. In terms of the sort of, you know, sort of guidance, I don't think the problem is so much around people being referred. I think what we're actually seeing is an increase in the number of young people requiring referral to CAMHS, and this is particularly sort of risen in sort of response to the pandemic and then beyond that. So what we're actually seeing is a rise in mental health issues amongst young people, rather than it being a problem with the referral itself, if that makes sense.
Can we come back to you, Councillor? Just mindful of time, Councillor Smith.
Thank you, Chair. Michael, thank you for the report and thank you for coming today. I'd like to ask, how long at the moment is the waiting list to be? Once you're referred to CAMHS, how long are these young people having to wait before they're being seen now? So if someone's referred in the last few weeks, how long realistically will it be before they get any care?
I'll have to come back to you with that one, the exact number as to where we are at this point in time with that, I'm afraid. But what I would say is that there is a risk assessment associated with it. So those that are deemed to be high risk will be seen much sooner. So they'll be seen within a matter of 2 or 3 weeks, as opposed to the significantly longer wait that other people are having.
Sorry, so I just want to come back on that. So if you're being referred, it's only a few weeks before you're seen?
No, if you are deemed to be at high risk,
okay,
then...
But what would happen then if someone is 17 and they have to wait 12 months and they go into the eye? Would that make it, so they're then 18 before they get seen? Does that mean that they would have to wait again on another list? I mean, I'm trying to...
No.
I have got some casework at the moment where a parent's telling me that they've been waiting 10 months after being referred. So I'm trying to get out of you. Is that about the time, or is it more?
It may well be longer. But what I would say to you, sorry, and you've got an interesting point about that sort of 17 and being referred, because one of the pieces of work that is being done is actually looking at that sort of transition so that people don't get into one system and then have to fall away and get into another system, so actually it carries across. So I know that there is work going on around that at the moment.
Thank you for that. Can you get back to the committee about, you know, the moment when you got the time to let us know how long the waiting list is, please? Thank you.
Just to follow up on Councillor Smith's question, I think what we're getting at there is if you're saying there's work ongoing, I think this is a problem that's been known about for a very long time, the transition to adults. And if there are issues with waiting times across that transition, I think it's something that we would probably want to hear back from you about how rapidly that's being addressed. I would say it's certainly something I've been aware of for a very, very long time. And it would be useful to know what steps have been taken historically to try and address that as well, maybe. If we could maybe get that kind of report back from you in a written form to this committee would be acceptable, I think. Thank you. Yeah, okay. Councillor Oxley.
Thank you, Chair. Thank you for the report. 2 questions. Wearing my day job hat, to what extent are you talking to the universities across Yorkshire and the Humber in terms of providing that treadmill, if you like, of certainly mental health nurses? Because obviously they're at the front of recruiting those students and in terms of directing those students. So to what degree are you talking to those universities and trying to provide that missing link in the recruitment that you're obviously struggling with? And it's not just you, it's other areas as well. The second one is something I've spoken about many times before. As a parent of a child with mental health issues, quite serious mental health issues, who then went through that waiting process in terms of getting referred to and then getting treatment through CAMHS. And talking to other parents in that similar situation, I've always felt that we are not doing nearly enough to support those parents because they're the everyday carers of those children. And I've always felt that very much you are left in the dark in terms of how to deal, how to talk, how to support your children in that situation. And obviously that's only going to be exacerbated with the waiting list. And I know the reasons why we've got those waiting lists. So my question there is, what more can we do to help parents of children, to help support their children until they can get the treatment that they need?
both writing. So I'll answer what I can, with the caveat that you can probably tell from my accent. I've only been here 3 months, so I'm learning a new system fairly well, but some answers are just answers. So your personal story is I'm glad that you feel you can share. That is the first thing, because that's quite a big thing to share. We do engage with our families. In one of our reports, there is a particular reference to how do we work with families, particularly in engagement in ward rounds, decision making, care planning. So we do at Sheffield Children's do have some training programs on that, but we ourselves acknowledge that there is more that we can do. We do work with young people groups, and I do think there are some parent groups. Jeff, I don't know if you know that there are any more things that I know of.
I don't think so. I think that is, sort of where we are. I think it's one of the things across the whole of the trust around waiting lists and the increasing size of waiting lists that we've seen in the last 3 or 4 years, particularly since the start of the pandemic, is around reassessing how we're managing those lists, because before that it was very much around let's just get the person seen, and now what we're realising is that it's going to be quite a long time before we can actually see people. So a lot of the work that is going on is around how do we support people in that period of time. So it is I'm saying waiting well, it's probably not the best way of describing it, but how do we actually support that? How do we make sure, and in CAMHS, how do we make sure the risk assessments, crisis plans are all in place? So actually, if, the young person where we tied does sort of go into a period of crisis, that there is actually a plan in place for them to make sure that, things can move forwards if that is required. So there is more to do, we absolutely recognise that, but actually it is one of the things, for better or worse, that we are thinking about much more across the board because the waiting lists have increased in size.
And our families, I know in the broadest sense, are our partners in care, aren't they? And not all our families have got the skills to do that, quite understandably. I don't have them. I'm not a mental health nurse. And so I do think going forward there's a real opportunity for us to engage more fully and actually help you understand the route you've chosen. Is that helpful route, or is it an unhelpful route in that situation?
I think as well, prevention is always better, and support to be able to prevent that issue escalating. And so I know from personal experience then that there is very little support. If you go to the various charity sites as well, there's very little advice, very little support for parents who are often tearing their hair out in terms of how do I support my child who's going some form of crisis. And I've said this a number of times in different forums, in terms of by providing that advice, I think it would certainly help parents and ultimately the children in those situations in terms of dealing with that. And I've seen the full caveat, if you like, of what's possible in terms of the scenarios that can arise with a child in that situation. And there is so little advice. And if there is, I would say, if there's one thing to try and help alleviate it, it's having something on the website that says, this is what you need to do, because I think it's that we are lacking in. And it's the type of thing, Sheffield University spent a lot of time training their security staff, for example, in terms of mental health training, because they're the first on the scene quite often. And that's paid dividends because they then know how to support a young person in crisis. So it's that similar help that people need to go to. And then my first question then, in terms of to what extent are you engaging with universities in Yorkshire and Humber?
Okay, so we have a good relationship with the 2 universities that I know of, which were the ones over the road from us. That said, my feeling is we take tiny numbers of students. I could count on two hands the number of student nurses certainly that we have at any one time. So I need to work out the reasons for that, because I think we could grow that. We're quite a small employer when you look at Sheffield teaching, and I think we can't wait until the middle of year 2, the beginning of year 3 to then declare we've got, you know, an offer here. I think we do go over to those two universities and speak, but actually I think we should be doing much more, much earlier, because paediatrics, not many people think of as a nursing career, because I think we just cuddle babies all day and we don't. But then to be a children's mental health nurse is something, unless you know about it, you don't even know exists. So that said, my view is we need to get in before university, because actually there's an option for children, young people who don't even go through university, to come and work with us as an anchor institution. So we should be starting in year 10 at school. And accessing it that way is my view. I don't know about doctors, Jeff, if you know any more about universities.
So yes, we take you know, a significant number of students. I think it's in their third sort of year across at Sheffield Children's. There is I'm sure you realise, an increasing number of medical students that are going through universities at the moment, and of those we are taking the majority into Sheffield Children's for their paediatric placements. So all medical students will have a paediatric placement. What it has to be is of a quality and, I'm going to say, enjoyment that actually makes people want to come back and go, actually, that's an interesting career, I'll think about that, and sort of take that forwards. There is teaching from psychiatry, so again, within the medical student curriculum, but again, you need to inspire people to want to do a particular job. And, you know, from my own memories of medical school, it's those people who engage with you and make their particular subspecialty interesting that actually are the ones that you're attracted to. Very few people will go for something. I met someone the other day who had decided they wanted to do paediatric surgery from about the age of 10. That is very rare. You know, don't know why she wanted to do that, but anyway, that was her choice. But generally speaking, you know, as you go through university and medical school, you're looking and going, which specialty do I want to go into? And it's the people that have that passion and that interest that really attract you.
Okay, so just following up on that then, how many vacancies have you currently got? And how many placement students could you take?
Oh, now the placement one I don't know. I'd have to work it out, because it does depend on how many active mentors we've got in the organisation. So I could pick a number out and it wouldn't be accurate, but I can certainly bring that number back to you. How many vacancies we've got? Not very many at all. I can't give you a whole number because it will be different today compared to yesterday. We have, in my experience, particularly in the world of paediatrics, and I'm very experienced, we have one of the lowest vacancy rates I know of. But don't let that lull you into a false sense of security. The vacancy rate is there. It was my preference to be over-recruited because the workforce, we have a growing number of, it's a young workforce, so maternity rates are high, and post-pandemic sickness rates are high, so a vacancy rate on its own isn't enough, really.
Thank you. I'm just going to squeeze a couple of questions in myself, and then if we've got time, Mary, I'll come back to you if that's all right. I wanted to ask what kind of involvement programme you have to bring in service users, parents, carers, in elements of co-design of services. So what kind of engagement programme do you have to hear from service users, particularly those who have experienced long waiting times, to hear from them what they would like to see improved in the system?
I'll begin. So if I talk more generally than CAMHS, because CAMHS is part of the whole integrated system really for us, So a couple of weeks ago I went to our youth forum, which is made up purely of young people who are patients or were patients, some for a very long time, some not very long at all. So they engage widely with exec directors, non-exec directors. They are very articulate in their view of what we can improve, so we listen to them closely. We also are involved with a group called Chili Pep, that you might know, which is another youth forum. So we engage through that. I am currently refreshing our patient and parent and carer engagement strategy. I think it's a little bit old-fashioned, and we could be a little bit more digital and savvy with the young people who aren't going to fill out a form. If it's not on your iPhone, they're really not going to engage. So we're refreshing that currently, but we are working with young people to do that and go design that. Anything you want to add, Jeff?
Yeah, I think just an example of the work, and it's a slightly different one, it's in recruitment. So, you know, again, quite recently, where we were recruiting for a psychology post, a senior psychology post within CAMHS, we actually have the Chili Pep actually do a separate meeting with the candidates to then feed back to the the people who are doing the recruitment, so that we do get the young person's voice not only in design of services but also in the recruitment to those services.
Chili Pep interviewed me.
Have we go.
Thank you. And just, I really want to just ask, sort of, what's the bottom line for you in terms of these improvements that you need to see? Do you feel that you have the resources you need coming from above, the resources you need to make the improvements you want in terms of workforce and service delivery? So thinking particularly about workforce, that it's a pernicious problem, isn't it, throughout health systems. So where do you turn for additional resource? What kind of steps are you taking to request what you need?
Thank you. I don't think it's about resource if you're talking about money. It's not about that. For me, it's about making the culture of the organisation one which makes us an employer of choice and you're prepared to travel to come and work here. I'm not saying money isn't nice, it is. I have enough money in the budget to recruit to all of the vacant posts. The exec team have just put additional funding in, particularly for CAMHS, so I can have over-recruitment in those services. So it isn't about a financial resource, it's just about having the time and the space to do some work with the culture, and I also believe with the national profile to make Sheffield an employer of choice where you want to travel to come. That's my view. Jeff might say it's all about the money.
I think it's around workforce planning, but I think a lot of the workforce planning is actually regional and national rather than local. We don't decide how many students go into the universities. We can have some sort of have our say as a stakeholder, but we're not the people making those decisions. And actually, in the longer term, those are the decisions that will make a difference to the workforce. Remembering that, you know, for example, from my thing, the medical students, that rise of medical students that, if you remember, came through as a policy 2 or 3 years ago, is still working through the medical student programme. It hasn't even got to the point where any of those people are yet doctors. And so we've still got a way to go from that particular initiative to get to a point where it's actually going to make a difference. That doesn't mean we shouldn't be doing it, but we should be looking longer term. I don't think the mental health, I'm going to say, crisis that people talk about at the moment is going to go away. This is the way it's going to be for the foreseeable future. And we need to make sure that actually the workforce planning is allowing for that as we go into the future. So we're not fighting from the same pool of people. And we do have to make ourselves the employer of choice when you're fighting in that pool. But what we need to be doing is actually having a pool to work from that is big enough for all the employers to actually be able to take from. So I think that's where we need to get to. We're not there yet.
So if I can ask just very quickly on that, do you expect support from the Integrated Care Board to support your requests and recognise the needs that you're saying you have? Are you looking to above in the system to advocate for what you feel you need?
Yes. So there are two bits to that. One is our CAMHS service. It's a little confusing because we're sort of commissioned through 3 different routes at the moment, which makes life slightly complicated. So some of our CAMHS services are commissioned through NHS England directly, and that's Emerald Lodge particularly. Then we've got those services that have been recruited through Provider Collaborative, Mental Health Provider Collaborative, for which we are the lead provider, which is across South Yorkshire and Bassetlaw, which again is around specialist services. So that's the General Adolescent Unit and the Ruby Lodge. So, and we are working closely with them. I had a meeting with them on Monday around their commissioning intentions for the next year, and actually taking some of this forward and what we actually require for the young people. And then more locally, obviously around some of the other services, which we are doing through the Integrated Care Board. But actually what there is as well is the development of another provider collaborative across South Yorkshire and Bassetlaw. So there are 2 slightly different provider collaboratives, but we are working closely with them. So there's another mental health provider collaborative, and but that's not quite up and running in the same way as our local provider collaborative, but it will get there. Sorry.
Okay, thanks. I've got Trish and then if we're a bit squeezed for time, but if we're quick, then we can come back to you, Councillor Lee. Okay.
Just very briefly, the Section 136 suite has been closed for a long time now. What's happening to children who need to be using Section 136? Are they still going into the police cells?
So they are going to the Northern General.
Right. Which isn't ideal.
No, absolutely.
Right. Very, very briefly, CAMHS has always struggled. Since 1982, I remember long waiting lists for CAMHS. They're huge now. And you're struggling, you're a small unit in a big city. Isn't it time to actually think perhaps of doing something like on the IAPT scheme and putting out more people actually into primary care in the communities, not so central, able to support the families and many of the children while they're waiting?
Yes, we do need to do more work with the in the community, and I accept completely what you're saying in that is one area. And again, where we would want to get to is the actual need for CAMHS goes down or doesn't continue to rise because of the support that's putting in and the early intervention that provides.
There was a scheme in schools set up. I know that COVID most probably kiboshed that, but has it actually reaped any reward?
It's still going, and yes, but again, it needs to go out further.
And I think just to add to that, my personal view would be as well, if we had parity of esteem in mental and physical health, we wouldn't be quite in the position that we are now. So that's part of the work that we're trying to affect.
Thank you. Councillor Lee had a comment.
Yeah, just building on that one, I guess. I suppose the whole range of mental health problems that children, young people experience, and from very early onset psychosis, which is very, very serious, and perhaps needs very, very quick intervention to allow the person to continue with their lives in school so they can meet the developmental steps they need to do, and also for the parents to get that support that they need to do to help manage and look after and take the right steps to care for their child. But it's about the IAP service, and many children suffering from anxiety or a low-level depression or even mid-level depression, then that can be treated in an IAP service. And 16 onwards, I'm not sure that 16 to 18 is such a gap that many children couldn't be helped within that kind of service.
Thank you. Can I just take your microphone? Thanks. Okay, so colleagues, I think we've picked up a number of issues that we'd like a report back on, if that's possible, please, that can just come in written form to the subcommittee. We may call on you to come back physically to a future meeting, but in the meantime, if we could get a report back on, I think what I've picked up is on your community engagement and co-design programme engagement with service users and parents, carers, on your recruitment strategy, and on the 17-18 adult transition management, and what's happening on that. Was there anything else, colleagues, that you'd like to hear back from? Is that everything we picked up? Okay, so we can get a written report back on that. That would be extremely helpful to us. Thank you. And in the meantime, then we note the report that you've brought. Thank you, and thank you very much for your time. So we go on to item 9 on our agenda, which is the Sheffield Teaching Hospitals Quality Strategy, and we have a report from our visitors. If you'd like to introduce yourselves and tell us about your role, and then bring your report. Thank you.
So, good afternoon, thank you for inviting us. I'm Jennifer Hill, I'm the Medical Director for Operations at the Trust.
And I'm Angie Legge, I'm the Quality Director for the Trust.
So, we're assuming you've scrutinised our paper, so Angie, just make a couple of opening comments, if that's all right, and then we're happy to take questions or comments.
So, it's just to say that our quality strategy, what we've tried to do is structure it around the DASI domains of quality and definition. So safety, experience and clinical effectiveness. And we've done that, aligning it to the National Patient Safety Strategy as well. So we're bringing that through into our plans for the future. And the key principle, I'm hoping you'll have noticed if reading through, is we need to engage better with patients, with the public. So it's really, a lot of it is about how we build those better engagements to help take the improvement work forward. So happy to take questions or comments.
Thank you very much. Would colleagues like to hear any more about the report or any particular questions? I've got slightly lost in my electronic documents, so apologies. Trying to make the switch to using electronic copies only, but it doesn't really work just yet. Do you know what page this starts on? Do colleagues have any questions? Councillor Mohammed. So I found my place now, sorry for faffing.
Very, very brief question. So I read the report. One thing that I wasn't clear on was how the quality of service would improve to reflect the needs of particular minority groups. I know that sort of black women were having problems within maternity wards, and it didn't sort of jump out to me in terms of how quality would be refined or addressed specifically to meet specific groups who have had particular problems within the Trust.
And to be fair, we haven't referenced specific groups in the strategy, but what we do want to do, and what is part of it, is we need to engage more with the different groups and voices that haven't been heard before, so we can actually build that in and find out how can we improve this, because at the moment everything isn't, we don't have a very clear, we need to do this and this will fix the problem. So it is very much about engaging with groups and seeking out particularly those that we haven't listened to before and trying to work out how, because there's quite often that there can be simple changes we can make, so it's going to be about listening for those.
Is there a plan of action about how you're going to engage with those groups?
That's being developed at the moment, so this is our draft strategy, and obviously there'll be an implementation plan that sits underneath it.
And just to add to that, sorry, as I'm sure you know, our maternity department is doing a lot of work, obviously after the CQC report, and working very closely with Maternity Voices partnership and using that as an opportunity to get feedback, using also our clearly other feedback, our friends and family test results, etc., and then using them to find groups to have further conversations with. So very aware of the need in maternity to listen more.
Thank you, Councillor Lee.
Yeah, I suppose what comes onto my casework is about people who are being discharged from hospitals, maybe to social care or to home care, and whether their experience and their family's experience, that whether they have enough time to discuss the future care with the staff and the medical staff and the nursing staff before they actually leave the hospital. I know sometimes you have a rapid turnaround. You want people who've gone through their medical treatment or their surgical and medical treatment. You know, you've done what you can, and people have to move on. Is there enough time spent with families and the patient, in discussing their future options and future care before they're discharged? Does somebody decide for the family and them, or are the family included in that decision as much as we would like them to be?
So I suppose a couple of things we've been trying very hard to do is, one, sort of personalised care, that what matters to you conversation early on with patients about what they want, but also planning for discharge from admission not in a how soon can we throw you out, but in a what are your wishes? Can we start thinking about that at the earliest possible stage, keeping people mobile, keeping them in their clothes, particularly older patients, but being very mindful of, clearly there's a group who don't necessarily have capacity to make their own decisions, where we clearly do have to involve, but being very careful with other patients to make sure that they're at the core of what the decisions that are being taken. It's not writ large in this quality strategy, but I think there is very much an emphasis on that individualised, personalised care, which is back to the what matters to you conversation, which we're absolutely pushing throughout all of the wards to encourage it. We haven't had an enormous, there isn't a loud voice of we're not getting that right, but that we're hearing, others may hear differently. So yeah, I think that's probably what I would say at this point.
Good
Councillor
question.
Smith.
Good question, Councillor. I believe that if patients are in hospital for a length of time, I'm not talking about 2 nights, but for a length of time, why you don't in some way contact them, even if they've gone home, to find out if they would fill in some kind of information. Because my husband was in hospital for 5 weeks, and I could have written you a book about the things that went wrong. And I didn't feel that, because I am a politician, I have made an official complaint, but most people don't. They go home, they're glad to be home, and that's the end of it. But you could learn such a lot from patients and relatives once that patient's gone home. And I'm a retired nurse, and I do think that, once people have gone home, they're forgotten about, but there's such a lot you could learn. So I think you should think about that in the future.
Yeah. No, that's a really fair point. I think our friends and family is a bit of a scratch of the surface. There is a lot more that we could do talking to people when they're in, and as you say, once you've gone home and had a couple of weeks to reflect what went on. Absolutely agree with you. Yeah.
Thank you, Chair. Any strategy is only as good as you can embed it into the workforce. Given the recognised problems that we have within, not just Sheffield, but everywhere else within the NHS in terms of workloads, caseloads, recruitment issues, how will you be able to embed this, given the workload of your workforce, where they're already struggling to do the day job and the night job and the weekend job, whilst trying to engage with this at the same time?
Yeah, that's $1 million question. I'll start, and Angie, you can come in. I suppose on things like the effectiveness side of it, we clearly have a central kind of corporate effectiveness team who coordinates a lot of the data collection. What is that telling us about our outcomes and how effective we are? So we're not so heavily reliant on frontline staff. Equally with the sort of safety strategy and the move to the sort of national patient safety moves that are underway at the moment. Again, we've got quite a really good central team driving those changes. We clearly need, where things go wrong, where we have to learn, we have to encourage our clinical staff to describe what went wrong, help us in the investigation. That's unavoidable. For example, we were talking about it this morning, our nurse recruitment levels and our nursing levels now in the trust are significantly better than they were 2-3 years ago. You know, we've had a huge influx of internationally educated nurses, and our recruitment now is not far off full recruitment, which is a really good place to be. Clearly, with our extra wards open because of delays in discharging, our nurses are spread very thin, so the pressure is high, but we're hopeful as some of those winter pressures and perhaps some of the other national funding we've had for care, that our wards will be able to shrink a little, our nurses will be a little less, and our medical staff a little less stressed, and that gives them a little bit more time to do some of that help with the safety work. Do you want to add, Angie?
Yeah, it's also about prioritisation. Safety and good experience, effectiveness, they have to happen anyway. They have to be part of the day job. So it's about supporting the staff to think about how they can prioritise and what is essential. And it's one of the things I'm looking at is which areas can we reduce a little bit? Is it more paperwork heavy that we can make slightly leaner to give people a bit more time to do the other safety essential work?
Okay, thank you. Trish?
Councillor Oxley has raised a really good point. Reading this twice, loads of words, terrific committees and groups, and somebody's everything to look at everything, except there's no training, support and trying to change the culture within the staff. Because they're under pressure, and loads of hospitals have failed because of a culture of failure and getting on. And your staff are okay, they're okay, you're not failing. You need to just support them and train them. But there's nothing about that in the strategy.
So there is reference a bit to the culture and the just culture work, and we're working with the Human Resources and OD team on the kind of how we do the training and the culture work and how we take that forward. I think what's important is what we don't want to do is overburden people with training. So it's also about thinking how we, again, make sure that it's purposeful and it helps move that culture conversation further. And one of the things we have done and is referenced, there is national patient safety training. Yes. At the moment, there's only been the 2 courses released, and I am delighted to say that as an organisation, we are doing well. We have 70% of staff have done level 1 and 53% of staff have done level 2. And we are ambitious to try and get everybody through that.
Okay. I think I'd like to ask, from a non-specialist, non-practitioner point of view, which is my personal point of view, it does seem likely that many patient safety issues stem directly from workforce deficiencies, so safe staffing numbers and the training issues that we've seen through various quality reports that have come to this committee. And improvement reports relating to CQC inspections. We keep seeing the issue of training and safe staffing levels. So, I mean, these are widely known about. It's not, there's nothing new, is there? But I wondered if you could comment a bit more about that from your perspective. And I think it's great to see that you're looking inwards to improve patient safety in every possible way. There's a great list of improvement measures that you want to undertake, and they do seem to be looking inwards at the organisations, but and that's brilliant, but I wondered if you look outside as well, what you would ask for to help you improve on a more sort of overseeing systematic level. So I guess to put it in a more cheeky way, if the Secretary of State was sitting in the room now, what would you ask for?
Okay, that's lots of questions. I'll come to that last one last. So training, I think, to be completely open, when we had the first CQC visit, our training levels were not where they should have been. They are now 90+% across the board. Our training is in a much, much better state. I think, well, not to make excuses. COVID and a whole bunch of other things meant that we hadn't given that the rigour that it should have had, but it is now back up at levels that are really very acceptable and being monitored regularly. And then I think the other thing to say about staffing levels, again, as I referenced earlier, we have made a huge increase in our nurse staffing numbers, and we also regularly, monthly, triangulate shifts where we were below our care hour, our expected care hours, and incidents that happened during that shift, to really carefully look to see, do we think that staffing levels accounted for at a particular incident? And we watch that really carefully, and we don't believe that that is having an impact. So we are very fortunate in Sheffield, actually, that our ward nurse staffing levels have remained at an acceptable level throughout the last 12 months plus. Clearly, the last few weeks have, as you will know, have seen unprecedented levels of pressure in the emergency department, ambulances, etc., etc. So I won't pretend to say that harm won't have been done while people were waiting to get in, either accessing transport or whatever reason they couldn't get to us with industrial action, etc., etc. But our inpatient areas, staffing and training levels, I don't think today, yesterday, the day before, are an ongoing concern and a risk to us. So that's hopefully the first part of your question. What would we ask the Secretary of State? Go on then,
I've got
Angela.
one. So I would actually ask for more money to go into building up the social care and aspects of more facilities outside of hospital to enable people to go home into good quality places.
Yeah, exactly what I would have said. Yeah, because we know at any one time we have 150 plus individuals who don't need to be in our hospital. They need to be somewhere, or they need some care, but they don't need to be in our hospital, and that's harming them by being pyjamaed, catching infections, not being mobile, and all the other things that unfortunately happen when you stay in hospital. And it's not a position we want to be in. And sorry, learning from others, I think was another question you asked. I think a couple of things. We are always looking to learn from others about where they do it well. We have a whole load of things. There's a Getting It Right First Time national programme where we're visited, specialists are visited, and we're told about places that do things well. We're very open to either where we do things well to share, but equally to go to others and say, you're doing really well at that. Can we learn why? So we're absolutely, and we do that regularly.
There's also there's a National Patient Safety Specialist Network that I'm a part of that has monthly meetings and webinars where we hear from experts in various fields. And that's been absolutely amazing, because we now get to hear and ask questions of experts who are at the forefront of thinking and how you improve in terms of safety and experience, etc. And I think that's really helping organisations to move forward in that regard.
That's great. Can I just ask, this is slightly off the remit of this report, but since you're here, can I ask, over more recent times, have you noticed any change in the seriousness and acuteness of patients who are admitted to hospital? So are difficulties in earlier care and intervention and primary care, are they resulting in you seeing greater need when patients come into hospital?
Yes, very definitely. Could I give you numbers and figures? Not easily, but anecdotally, unquestionably, people's access to primary care is tricky, and therefore they're presenting at a later stage, interestingly, and probably as much because of COVID as anything else. Our cardiac surgeons were telling us last week, having said I couldn't give you any numbers, they've changed from doing 80% planned, 20% emergency heart surgery to 50% emergency and 50% planned heart surgery. And that will be because people either didn't or couldn't access blood pressure, angina control, and have turned up in crises and ended up in emergency. So I think that's mirrored throughout the country. So how much of it's COVID per people didn't go and or now? So a lot of those conditions have progressed and are presenting at a later stage. But also we anecdotally hear very frequent reports of, I couldn't get to my GP, so I've come to A&E, because of course we're open, aren't we? And so we're used a lot like primary care.
Is that resulting in longer stays in hospital as well?
I think That one's difficult because there's so many confounding factors with that, particularly access to social care to leave hospital is affecting our length of stay, unquestionably. There are a number of patients who, whilst they're waiting on long waiting lists for procedures, are becoming less well and coming in with, I don't know, a flare-up of their kidney stones or their gallstones because they haven't been able to access the surgery, and or their hip replacement condition is getting worse. So I think people are deteriorating and therefore less well when they come in, but what exactly you put that down to is quite tricksy because I'm sure it's multifactorial.
Thank you. Anyone else? Last chance.
I suppose it's what you were referring to before about that interface between yourselves, health and social care, and getting that right. And my belief is keep people on their legs whilst they're in hospital. That goes a good way to making sure that they can transfer more easily and more quickly to, and I'm not being crude, but I just keep people mobile and independently mobile whilst they're in hospital. I think it's too easy to, when staff are under pressure and very, very busy, to do things for people, and that doesn't help in the longer term, and just to avoid that. And I'm sure everybody has that thought in their minds when they're planning care and doing care and so on, but it is important.
Absolutely, and our therapy staff, our physiotherapists and occupational therapists, over the last 6 months have been covering 6 additional wards which have been open because of the pressure that we've been under. So same amount of staff stretched a bit thinner, and inevitably that means that the care an individual patient gets is significantly reduced. So absolutely, we would love that not to be the case, and for the level of encouragement to be as it should be from nursing and therapy staff.
The comment, Chair.
All right.
Go back to what I mentioned earlier, that I mean, I feel that such a lot of people end up in hospital because there is not enough primary care, and I dare say they can't get in touch with the GP and get an appointment, so it ends up sometimes being a little bit more of an emergency, so they go to A&E, they ending up in hospital. So I really do believe that we need to look at that and get the figures, because I think it must be massive, to be fair. And how do we do that? The only way you can do that is speak to patients and their relatives to find out why. Because I know that from experience, personal experience, that if you can't get in touch with a GP, you just let things ride and then it can become an emergency and then you end up in hospital. And I think if we don't start asking questions, we'll never get the answers. We'll never change what's happening. Sorry.
Yeah, no, so I think you're right, and I think we know that's, and when we talk to our primary care colleagues, they're absolutely buried in workload. So I think the more we can do to make it to make it easy for people in need to ring one number and get the right thing, be that the walk-in centre or a GP or whatever, we need to improve the access to urgent on-the-day primary care, and it might not be your GP, it might be a GP. So we're having some conversations across the city with primary care colleagues about how we can help to do that, because I think it's not that GPs are on the golf course. I think they are quite definitely buried in workload, and we're picking up the consequence of that. It's not their fault, they're buried in work. So I think we just need to work together to see how we can make it easy to access something which is a responsive service which prevents the default to A&E admission and all the damage that occurs thereafter. So I totally agree with you. But I think we know it and they know it. So I'm not sure the data's needed. I think we just need to do something. We need to find a way to do something about it.
I'd just like to ask off the back of that really, do you feel that the South Yorkshire healthcare strategy that's currently sort of moving towards an implementation plan with the ICB, so the strategy paper that's come from the Integrated Care Partnership, I don't know if you've had a chance to scrutinise that yourselves. Do you feel, though, that level of strategy is going to address some of these issues of improving access to primary care, so that this extra burden on hospital care is eventually, the strain is taken off and patients are seen where they should be seen earlier on in primary care?
So I believe I was sent that document on Friday afternoon after a meeting, and I have to admit it's not yet reached my reading pile. Most of the conversations I've been part of from the Acute Federation, the South Yorkshire Hospital side, hasn't talked a lot about primary care. It's been a lot about fragile services, fragile hospital services, and work to improve those. So I can't comment whether it does that because I haven't read it yet, is the honest answer to your question. Don't know.
I think that's possibly a question I'd like to follow up, really, if there's a route to do that. I think with the teaching hospitals, to hear back from you as to your, what you think, well, whether you think that strategy paper is addressing the issues adequately. So I think there's a window at the moment to for a scrutiny on a South Yorkshire footing to ask questions about that, and on a Sheffield Place basis as well.
Yes, I think Emma Latimer et al. would be well placed to perhaps comment as well from a Sheffield perspective, wouldn't they? Because they see that primary care probably that bit closer than we do, but certainly I'll have a look at it too. Yeah.
If you and your colleagues would have a chance to scrutinise the paper and send us any comments you might have,
Yes, I can talk to them.
that would be really useful to inform our comments then. Thank you. Anything further? Okay, thank you very much for your time then and for bringing that report. Extremely enlightening, and I'm sure it's probably opened up more questions that we will want to go away and think about as well. So no doubt we'll invite you back in the future for more on that. There was one thing I wrote down that we might want to ask you for. Sorry. Just 1 second. Oh yeah, so you mentioned early on an implementation plan will underpin this this paper that you brought today. That was it. So today we're looking at a draft strategy today, and you said there'll be an implementation plan that will underpin that. I wonder if we can hear back from you with that implementation plan in due course.
Yeah, I'm not sure that's quite what we meant, was it?
So there will actually be 3 implementation plans, one for each section, because each section largely sits under different teams under me. So there will be plans, but they will be at different stages before they're firmed up. Yeah. So while the patient experience one is likely to be ready in the next few months, the clinical effectiveness one will take quite a bit longer.
And safety is a work in progress. So, so I suppose it's quite it's quite multifaceted.
Yeah, the safety
thing.
one
doesn't sit in one bit. That's the problem.
Yeah, the safety one is emerging as things goes on, because it's part of the strategy, and we need to develop the patient safety incident response plan, which will then inform how we then take things forward. And again, the plan will change on an annual basis as new themes emerge and we take things forward.
So I think probably those levels of detail are more than this subcommittee needs to be concerned with, but I think on the patient engagement side of things, we'd be quite interested to hear back.
Okay.
I'm looking at Trish particularly on that. Would we like to hear more back about patient engagement?
Definitely. Yeah. The other thing is I need to just perhaps get minuted the fact that Healthwatch Sheffield has responded in writing to this draft report.
Yes, and you have colleagues on our patient experience engagement group and committee, so very well plugged into feedback. Yeah.
Which will also be monitoring the delivery of the plan.
Yeah, if we could just receive a report from you specifically on the engagement side, that would be really useful. Thank you. So thank you very much for your time today and for answering all our questions. So, colleagues, we've just got the work programme to look at now, and I think I'm supposed to say that we've officially noted the report that was brought there. We have to say that. Okay. So the work programme, which you've got a paper copy in front of you. So we're just looking at items that now remain for the March meeting and any items that aren't yet timetabled. So if members have any comments about anything forthcoming on the work programme, anything you'd like to add, anything you think should be prioritised? So I'd probably draw your attention to the continence services, which is something that we last heard about. Well, at our next meeting in March, that will be then a year since we last heard a report on that. So would colleagues like to have something come back on that? We can move that up to March, or we can plan it for later in the year. Resounding silence. If that's not considered urgent, I think we can we mark that down for the following meeting. After that on the work programme, we've got similarly an update on improving maternity services. That was a more recent item that we heard at this subcommittee in September, and I think we probably suggested a 6-month report on that, so that would come up in March. Do we want to take that in March if time allows? Okay. The commissioning in place, just above that, to receive an update on developments of South Yorkshire in terms of the Integrated Care Board and the establishment of the Sheffield Place Committee. I, for one, would like to hear more about that sooner rather than later, so we can understand how the structures are developing and what role Sheffield Place has within the integrated care system. So I think if we could ask Emma Latimer to bring a report to that, or actually we could take that as a members' briefing, as a separate from the public meeting. Would that? We could take that as a members' briefing if we want to be able to spend a bit more time on that with Emma. The update to developments on the ICB. We want to see if we can we see if there's room in the March meeting for that.
Absolutely, if that's what members want. I'm just wondering if there are any items that are currently on the March meeting that maybe
we could move. I think
maybe could be deprioritised if that's possible.
Well, I think we could deprioritise the First Hill Rise item, as that was only relatively recent anyway, and make room for an ICB report. I think particularly we'd like to hear from Emma Latimer as Place Director about the role of the Sheffield Place within the system, and I mean I don't even know what the Sheffield Place is officially called. I think we're probably all a bit behind the curve on how that's playing out, so that would be useful to have a report.
Is there any further information on the composition of the ICB and how we feed up into it as well? Because I'm seeing people that are sat on there and I just think, well, how on earth has this happened? These aren't sort of health reps, so I would be interested to know how the composition has come about and why there is no formal structure for this group or the adult health and social care group to be able to feed into that.
I think we can ask Emma to include something on that and maybe bring someone from the ICB as well. In the meantime, we can send written questions to the next ICB meeting. If you've got specific questions for them to address at a public meeting, we can submit a question as a committee, as a subcommittee to the next ICB, to the next board meeting.
It'd be useful.
Yes, so the joint South Yorkshire and Basset Law Joint Health Scrutiny Overview Committee did recently have a members' briefing, and we can share the presentation that was brought to that, which might help to inform it more as well. But certainly we'll include that wider ICB discussion if we can bring Emma Latimer to the March meeting. Does that fulfil what you were asking? Yeah. Yeah. And if members have any questions to put directly to the board, just either send them in yourself or we can send them via this subcommittee. I think, do we want to hear back about the relocation of the step-down services again at any time soon, or just keep that on the future programme? Yeah, we can leave that till we've got a suitable space, I think. And primary care workshop, so this, I think, is to be a separate item from the public meetings. This was a request of mine, actually, to hear from practitioners in primary care in Sheffield about what their on-the-ground experiences are, and to hear what kind of challenges they're facing and how they would like to see them addressed system-wide. So that's to be arranged to hold some kind of workshop session where we can...
Have you got an idea of a time frame on that? Do you want it to be before the election?
I think, if possible, I'd like it to be before... I mean, it's always urgent, isn't it, primary care? But if we can look at possibly arranging an initial date for a workshop session. Has that covered everything on the forward programme?
Yeah.
Okay, and then I've got one additional item which I'd asked for verbally before, really, so it's my fault that I hadn't really put this down in writing, but I'd like to hear a report on urgent care provision, and this is really following up from 2018 when the walk-in centre and minor injuries unit were not closed and not relocated to the Northern General, and really just to ask for a report on the state of those provisions since 2018, and details such as the length of contracts that were in place, the staffing levels at the walk-in centre particularly. I'm interested in waiting times there, and whether there are any future plans for any reconfiguration or change of service. I'm looking at Steve particularly because you were very involved in that previously. Steve, does that cover the kind of questions we want to ask around urgent care? Happy with that? Yeah, thanks. Anything else for the work programme? Okay, well, so we seem to have finished very early, which is excellent. We can all go home and have a little bit of spare time. So thank you very much, colleagues, and thanks for all your questions today, which have been extremely insightful and helpful. Thank you.